So for the second session of this review, we are pleased to invite the chairpersons, Professor Babar Salim, Professor and Consultant Rheumatologist at Fauji Foundation Hospital, Rawalpindi, and Dr. Alam Zaib, Consultant Rheumatologist at Khyber Teaching Hospital, Peshawar, as the chairpersons, along with Dr. Syed Ali Rokh from Quaid-e-Azam Medical College, Bahawalpur, as the co-chair. Please join us on stage, our worthy chairs.
Our next distinguished speaker is Professor Dr. Muhammad Haroon, Head of Department of Rheumatology at Fatma Memorial Hospital and FMH College of Dentistry, Lahore, Pakistan. Today, he will be speaking on a topic of significant clinical relevance, difficult to treat and complex to manage psoriatic arthritis. Please join me in welcoming Professor Dr. Muhammad Haroon to the stage.
Assalamu alaikum, and sorry, a bit strepsily. I was expecting this going to be a tea break. Assalamu alaikum, and very good morning to everyone. It's an absolute pleasure to be with you guys on the stage and talking about my favorite topic, psoriatic arthritis. Of course, it's going to be a little different, talking about the difficult to treat and, of course, complex to manage. I requested Dr. Ahmed about this topic because this is a very topical right now. Of course, has been quite a recent developments on it. So the first thing we'll be talking about defining, because we have now the formal definition, how we define difficult to treat and complex to manage psoriatic arthritis. And the second part, I'm going to touch a little bit about some new updates in regarding psoriatic arthritis, some new studies kicking in, and some new, I must say, some take-home messages, for treating physicians. So psoriatic arthritis, we know, is a progressive immune-mediated inflammatory joint disease, and we know I don't need to make a case that it's not a mild disease. It's a complex disease. It's a progressive deforming disease. Even my own center in Dublin, some time ago, very long time ago, it showed that up to 47% of the patient, even though they were on DMARDs, and within 2 years they developed erosive joint disease. And the same was from the Toronto group. It has shown that 67% of the patients, when they first presented to a rheumatologist with the psoriatic arthritis, they already have had a radiographic erosion at that time. So we are talking about not a mild disease. And we know the diagnostic delays, and we know that's quite prevalent, as goes around 30 to 40% of the patient with the skin psoriasis would develop psoriatic arthritis at some stage. We know that it might take up to 10 years, but in certain genetic subsets, for example, with the HLA-B27 and HLA-B08, for example, there is a very earlier development of psoriatic arthritis among the patients with the skin psoriasis. And we know that remarkable number of patients with the psoriatic arthritis, they remain refractory to treatment, and those are the patients that we'll be talking today. So we didn't know much about how to define, what are the patients, who are the patients who we can label at difficult to diagnose or difficult to treat rather psoriatic arthritis. And that was a big dilemma, because if you look at the studies earlier on, people used to talk about the failure, for example, to a convention synthetic DMARDs or a biologic, or how many biologics need to be failed before you label some patient as difficult to treat. And actually, there was overdiagnosis as well, and of course, conversely, there was an underdiagnosis as well at the same time. So we know that in psoriatic arthritis, there was a significant number of patients who would have some psychological sort of condition, some issues with the mental health. We know very well about the high prevalence of chronic fatigue and chronic pains and so on. So this is not a simple mix, rather quite a complex mix of patients. For example, a study from the lower courts from UK has shown that nearly 70% of the patients with the psoriatic arthritis would have some form of mental health issues going on with that. And around more than 50% of the patient, imagine more than 50% of the patient would have issues as regards their intimate relationships. And around 44% of the patients have some issues as regards relationship with their family and the friends. So you're not talking about a simple joint disease alone. We are talking about a complex disease which is impacting a lot of issues, not just the physical health, but also significant impact of the mental health. And that is why it is not surprise that in spite of all the new drug developments we talk about, in psoriatic arthritis, at least in last 2 decades, we have witnessed significant sort of explosion of all those new biologics and targeted synthetic DMARDs kicking in. And the latest of all is the TYK2. And again, we are not getting the results. We are, of course, on the subset, on the outlook, we are getting the results. But look at it. Still, there are 50% of the patients who do not achieve ACR 50, and around about the same is that they don't get the MDA in the long run. And if you look at the convention synthetic DMARDs, for example, there are only about 40% of the patient who would achieve a good clinical response in the long run if we talk about the convention synthetic DMARDs. So it means we are not getting the results in the long run among these patients. And that's why, and if you look at the clinical trial, for example, of the patient with the difficult to treat psoriatic arthritis, they talk about just the active disease, the disease activity as regards the arthritis, as regards the enthesitis, as regards the axial disease, but not a big mention, not a sort of emphasis on other aspects, which of course impact on a patient with the psoriatic arthritis. And we know that inflammation is not the only aspect which would lead to symptomatic, for example, the patient is still there. We know about the concomitant fibromyalgia. We know about the complication related to immunotherapy. For example, look at the patient who has, for example, drug-related side effects, and we are not able to escalate the drug dosages. And these are the patients, of course, some people can easily label them as difficult to treat, but they're not like difficult to treat. We should be talking about or labeling them with something else. And that is the whole emphasis as regards what to do with these patients. And of course, the whole dilemma is not just unique to psoriatic arthritis. We know in rheumatoid arthritis, for example, we have the EU law has formally defined what the difficult to treat rheumatoid arthritis is. And in ASAS is also talking about coming up with the formal definition of difficult to treat in axial spondyloarthritis. And GRAPPA finally has managed to establish the formal the diagnosis of how you define difficult to treat. And that is how, what they did was, the GRAPPA did in very elaborative way is the 3-tiered fashion, how they ended up with the formal definition. One is, of course, doing the literature review to find out what actually is out there, how in the previous studies, how the people have defined difficult to treat, and that is literature review. We'll talk about this. And then in the second one, they talk about the real world perspective, talking to the clinician, talking to the patient, and asking them what are the factors who would lead to, or what in their mind, who are the patient with the difficult to treat and complex to manage. And in the finally, bringing all those, what they have gathered from the literature review, from the real world sort of the perspectives, and then talking about the Delphi exercise of the experts, the steering committee, and then finally sending an online service to all the GRAPPA members, and finally coming up with the formal definition. So this is literature review. If you look at, for example, so 33% of the patient, the 33% of the studies in the literature review, what they showed was that for example, this one, failure of one conventional synthetic DMARD and one biologic DMARD. So that's how in the previous studies, they have defined difficult to treat, 33%. And in 27% of the previous studies had come up with the definition that the patient would have to have a failure of 2 biologic DMARDs before you can label them as difficult to treat psoriatic arthritis. Talking about the health surveys, and these were the interesting ones. For example, they asked was difficult to treat, and look at for example, these are the healthcare profession. They're talking about who would they label as difficult to treat, and that's fair enough, and that's actually what we think as well, probably. These are the patients who have difficult to treat inflammatory disease, right? And the complex to manage, for example, when they were asked about those, look at this, all those talking about for example, the chronic fatigue, chronic pain, the comorbidities and all this. So there was clearly some separation, if you want, is when they're talking about the difficult to treat compared to complex to manage psoriatic arthritis. So there's the interesting split, if you want, from those two things. And then this is the formal definition of now, just published, just presented as well at the EULAR 2025, is that when you're talking about the difficult to treat psoriatic arthritis, you should be labeling that particular patient should have around 3 treatment failures. Among those 3 treatment failures, there has to be 2 biologics or targeted synthetic DMARDs failure. And this is important and valuable for research and clinical trial. So at least in the clinical trial, we're talking about a true failure of that refractory treatment failures patient, rather than talking about the complex to manage, rather than the patient who have still the active disease because they have other comorbidities going on. And then they separate this into the other group is complex to manage. And that is a little sort of the broader area which encompasses the other issues which are important to the patient as well. And that's why they are still symptomatic. For example, we just spoke about fibromyalgia, for example, or other comorbidities which are still bothering the patient and ending up having an active disease. So I think that was the important thing, is that the split of these 2 definitions, at least for the clinical trials in the future, is very, very helpful. So that's the first part. So the second part, I don't know, quite recently I read this, I don't know how it came up in my sort of slideshow, was this is a famous book, not that famous, but the Roger Rolls from talking about the disease, doctor and doctorate. And it's a little bit from the UK, if you talk about the concept of the thermal therapies and all this, the thermal spraying, spa doctors and all this. And that is a little bit about the history, that how all these treatments with the psoriatic arthritis and of course the some arthritis treatments. And initially talking about the 60s and 70s, that's what they talk about, and in 80s, they used to treat patients with arthritis with all those thermal waters, thermal springs and all this. So there's nice pictures and all this. So I thought I'll just show it to you that how all these treatments, and now we are talking about all the latest drug developments, but I was surprised to look at this gentleman. And I'm not sure whether it's just the thermal water or it's just the company that is enjoying. So that's how these thermal waters and all this, you can look at all those. So I thought just to show it up there, and I believe there's still like sort of the thermal or the cold, the hot waters and all this, the heat therapies still to date works very well. But at that time, that was the mainstay of treatment, if you want. We are talking about the 60s and 70s. And this slide is of 2016-17, and you can see this is the whole new drug developments. The whole area is expanding, and this is again 2 years old. I mean, you're talking about all new drugs and all this coming on board. We have GRAPPA 21, which has also like sort of compiled all these. And I believe right now GRAPPA is in the process of compilation of the latest updates as regards the treatment guidelines and all this. We have the APLAR as well, and thankfully we shared as well. I was the part of the working and the part of the steering committee member, and we have also the patient partner as well who contributed to that, as got the patient perspective in terms of coming up with a formal recommendation how to treat psoriatic arthritis. So there was a very good exercise for us as well and for my patients as well. So let's talk about this. This is one of the latest just presented at the EULAR 2025. And this is very important for me, to be honest, when I looked at. I don't know how many of you guys remember back in, I think there was 2018 when I presented my first 50 patients when I landed in the country. And I think it was in Karachi. First 50 patients in psoriatic arthritis who I started on methotrexate here because, of course, the availability of the biologics and all this. And I was very surprised that the methotrexate does work very well. And that was the time when the methotrexate was not formally in the guideline as regards in psoriatic arthritis. We used to talk about moving straight to anti-TNF sooner rather than later. So this was a randomized controlled trial talking about starting methotrexate and, of course, a biologic DMARD at a first-line treatment. So we have a naive patient, DMARD naive patient, starting on a DMARDs, and disease duration less than 2 years, active disease and naive to DMARDs. And all these patients were having 15 milligram of methotrexate started at day 1. And then they were started, one arm given the golimumab, and the other group was given placebo. So the two groups started on 15 milligram of methotrexate. One was given anti-TNF, and the other group was the placebo. And bang, bang, what surprise. At week 24, there was no difference. No difference in the primary and the secondary endpoint. And at week 24, the golimumab was stopped. the anti-TNF was stopped. And then the same, like the methotrexate and of course, the continued. And by week 52, there was still no difference. So it means the anti-TNF introduction, even at the day one, even at the outset, in the patient with the active disease, at least in the 6 months time point, 12 months time point, and the difference was very much comparable. And what was that? And to me, I think was because in these patients, methotrexate was very rapidly titrated up to the dose of 25, regardless what. So all these patients started on 15 milligram, and within a month, the dose was escalated to 25 milligram within a month. So the very rapid dose escalation to the maximum and achieved exactly the same results week 24 and talking about the week 52. Of course, life is not that simple. So the difference was a little different if you look at the details. Of course, with anti-TNF, there was a much less usage of steroids compared to the placebo and the methotrexate, where there was a little higher usage of methotrexate, the steroids as a rescue. So the rapid escalation of methotrexate was almost comparable to anti-TNF. And this brings me to the second study. This was secukinumab, early secukinumab versus methotrexate, very much comparable, the same. The one group was given the secukinumab, 15 milligram of methotrexate, rapidly escalated to 25 milligram of methotrexate, and standard of care was the early secukinumab. Look at the dose, 300 milligram every 4 weeks, right? And the methotrexate was 15 milligram. And in the second group was 25 milligram of methotrexate. Started with the 15, as I said. Within a month, dose was escalated to 25 milligram. So to me, 300 milligram is a higher enough dose because we start with the 15, about 150 milligram. But again, the primary endpoint, there was absolutely no difference. So we're talking about ACR 50, 20, 70, you name it. All those, even the skin scores. So I was surprised. So again, talking about the escalation of the methotrexate to the rapid higher doses is almost comparable to the TNFs that you talk about. This is a little older study, but it's important to bring this here. This is a control study, talking about more or less the same, that the methotrexate 15 milligram, active disease, and then they are randomized to adalimumab versus the escalated methotrexate, right? But here what we are seeing is by week 16, that the patients were given methotrexate, only 13% achieved MDA compared to 41%. So there's a big difference here. Very much different to what we just spoke about last two. They were also randomized control trial, the two, but this is different. So what's the difference here? So only thing difference was, sorry, something is missing. So only thing different was that in the patient who would escalate the methotrexate in the control clinical trial, they were escalated very slow escalation of methotrexate. They were given the escalation of 5 milligrams of methotrexate. They were started with the 10 milligram. Dose was escalated 5 milligram every second week. So reaching up to 20 or 25 milligram, it was up to 2 months or thereabouts. So it was a very slow escalation of methotrexate in this particular clinical trial. And what we saw was that we got suboptimal response in these patients. So there was a very interesting, at least a learning for me was that how we should be taking the methotrexate or escalating the methotrexate if we want to rely on the methotrexate to control the disease in psoriatic arthritis. Talking about the initial DMARDs, methotrexate compared to rheumatoid arthritis, I mean, look at the methotrexate. We are talking about psoriatic arthritis versus the rheumatoid arthritis. Unfortunately, psoriatic arthritis patients, either, no matter whether we are talking about the high disease activity or the moderate disease activity, unfortunately, either they are not getting enough DMARDs, either usually with the higher number of the monotherapy or no DMARDs compared to rheumatoid arthritis, and hardly many, very, very few, if you want, the psoriatic arthritis patient had multiple biologic DMARDs or anything. So clearly, the psoriatic arthritis patient, they're not getting enough DMARDs, and forget about having the multiple DMARDs compared to rheumatoid arthritis. So just making a case that the psoriatic arthritis patient, unfortunately, they do not get the proper DMARDs very early on. There's a lot of delay there. This study clearly showing that apremilast, for example, talking about randomization, apremilast started with, on one end, the placebo. These are the oligoarticular patients, oligoarticular psoriatic arthritis patients. On one end, they were given apremilast versus placebo. So very interesting if you look at, for example, here is a baseline. This is the placebo group. This is a placebo group, and this is you're talking about the patient with apremilast. So there's a very, the patient who were given placebo, there was a high likelihood that these patients moved into the more polyarticular stage rather than the oligoarticular. So by week 16, the placebo patients were moved into the, what you call the polyarticular compared to the oligoarticular. And then they were given apremilast, and then gradually they moved down into the oligoarticular. So if you treat patients early and aggressively, the oligoarticular patients, of course, can remain either they go into remission or at least they would have reduced sort of moving into more oligoarticular. The clinician know very well that the drugs don't work all the time. We are talking about here the patients who have got a TNF experienced patient. So the TNF experienced patient usually would have a more further reduction as they don't respond that well to this further subsequent treatments. Sorry, I'm already a little late. So talking about the sequential treatments, sorry, just 2 minutes. So we're talking about the sequential treatments in psoriatic arthritis. We're talking about the patients who have already failed biologics, and now we're moving into the second, for example, biologics or the third biologics. If we look at the literature, for example, we know very little beyond 3, for example, the treatment failure, 3 biologic failures. All the data we have is these are the published, for example, and these are the abstracts. So we have good evidence, for example, for the first line and the second line, and subsequent we have very little information. However, if you look at the TNF, for example, the DAPSA remission compared to non-TNF inhibited DAPSA remission, here we are seeing is a very good response with the first, for example, first line TNF. Subsequently, of course, we don't get the same response. Third one is further. So there is a clearly diminished response with the further, the more moving on towards the, what you call the loss of response, if you want, with the further moving into the anti-TNFs or the other agents if you talk about. And this is the large observational cohort study from UK. And it's very interesting if you look at, for example, these are the box plots and the estimated probability. So the best what you can get is the greatest likelihood of response is the odds ratio of 1.91 is with the first line anti-TNF, and the further down there is a reduction in the response, but we are still getting the good response, the odds ratio of 1.13. So it doesn't mean that after the first treatment failure of the biologics that we are not getting the response. We are getting the response, but there is a diminished response. And this is in the skin psoriasis, for example. If you look at this is the Foster, again, don't need to worry too much about it, but you look at the first line, second line, third line, and fourth line, and here is the pyramid looking at the pooled effect, and clearly it's below 1, means you're getting the response. And so it means whether you're talking about the first line anti-TNF, second line biologic, or the third line biologics, these drugs do work, so we should not be worrying too much. The non-conventional combination, I'll move into the next one, sorry, just for the sake of the time. This is a very, very interesting, just published. And we know very much about all the weight loss and all this, and the benefit in psoriatic arthritis, skin psoriasis. You're talking about here in a randomized trial, crossover trial. So study population randomized into, just for 8 weeks, either they were getting keto diet or they're getting the Mediterranean diet. So we know about the keto diet a little bit. We know about the low carbohydrates, of course, increase in proteins and the fat. And we know the Mediterranean diet a little bit. I know when we talk about the Mediterranean, we think about the wine and all the olives. But if you look at the Mediterranean, there's high consumption of fruit, vegetables, and cereals. There is a modern consumption of fish and all this. So these patients were given over an 8-week period keto diet versus the Mediterranean diet. And afterwards, the washout, and they were crossover. So very interesting that with the group, both groups, they achieved good weight reduction, whether you were given the Mediterranean diet versus the keto diet. So the weight reduction was very much optimal, very much optimal. But the only difference was there was a significant, the DAPSA and the PASI in the patient who were given keto diet compared to the Mediterranean diet. So means just the weight loss alone is not enough, but rather getting the weight loss with the Mediterranean diet was not enough to reduce down the DAPSA response or getting the PASI scores. So that was possible through the keto diet. I don't know whatever the difference was, whether the low protein or something, high protein or the fat thing that was, but there was a clear difference there. That because I used to think was this the weight loss, but this particular just published this year that has shown that the difference is not just the weight, but the keto diet was much superior, statistically significant compared to the Mediterranean diet. Sorry, that's my part. Sorry for the delay.
Thank you, Dr. Haroon, for such a comprehensive presentation. We now have the honor of hearing from Professor Hasan Tahir, Professor and Consultant Rheumatologist at the Royal Free London NHS Foundation Trust, United Kingdom. Professor Tahir is a distinguished clinician and educator whose contributions to rheumatology extend across both clinical innovation and academic advancement. His presentation, Precision Medicine in Axial SPA, delves into a cutting-edge approach shaping the future of patient care. Please join me in warmly welcoming Professor Hasan Tahir to the stage.
Thank you very much for inviting me, and thank you to the PSR for the invite. What I'm going to be doing today is going to be talking about precision medicine and Axial SPA, and talk about a case and walk you through a case and hopefully address this particular topic. These are my disclosures. So let's start with our case. We've got a 30-year-old female patient who's overweight, BMI of 30. Primary symptoms, persistent back pain for 7 years, helped with naproxen. She's seen by multiple healthcare professionals, physiotherapy, GPs, osteopaths, chiropractors, in fact, seen multiple times over the period of 7 years. Not a very unfamiliar situation that we're seeing in our clinics. Smoker, and she's actively planning pregnancy. One of the key things, or my biggest interest I've had over the last 15, 16 years in Axial SPA is early diagnosis. And one of the key things about early diagnosis is public awareness. One of the programs that we've been running is a public awareness program in not only our hospitals, but in gyms. And what you've got is you'll come into our hospitals, for example, our hospital, and have got these banners up alerting patients about back pain and telling them the difference between inflammatory and mechanical back pain. There's a little QR code that patients can actually use their phones and actually go through their symptomatology. And if it highlights that they do have inflammatory back pain, it generates a letter for them to take to their GPs to refer patients to any rheumatology service. This patient happened to be in our trust who happened to see this sign and actually clicked on the QR code and it alerted them that they could have inflammatory back pain. In fact, they were referred to our service and we ended up seeing them in clinics a few years back. This patient, we've gone through the story, but to add a bit more, as I said, 7 years of back pain, morning stiffness, fatigue, persistent Achilles tendinopathy, itchy scalp, and previous episode of left knee pain, just to add to the history. So it's not just back pain. Blood tests, HLA-B27 positive, raised inflammatory markers. We did an X-ray. X-ray showed no radiographic changes. That prompted us to do an MRI. That showed no inflammatory changes. However, if you did a disease activity score, there was a high disease burden. So what's the diagnosis? Does this patient have axial spondyloarthropathy? Can they be discharged? And unfortunately, what tends to happen is we are seeing patients like this who, just because they have normal X-rays, normal MRIs, they are discharged. However, from our point of view, if you look at the 2009 criteria, admittedly, these are classification criteria and not diagnostic criteria. If you go through this patient, despite having negative imaging, they are HLA-B27 positive, and they have a number of these features. They've got the inflammatory back pain, but they had the enthesitis, they had itchy scalp, probably psoriasis, good response to anti-inflammatories, and elevated inflammatory markers. So they do have what we would call clinical axial SPA. Patient was kept on obviously in our clinic. referred for physiotherapy, anti-inflammatories changed, before I move on to that, those of you going to the ACR next week, these are new classification criteria that are probably going to be discussed, in which they, rather than the old 2009 criteria, this is how we're going to be looking at patients with axial SPA with a 11-point cutoff. So in our particular patient, even though they didn't have axial SPA, they were HLA-B27 positive, so 4 points, they had inflammatory back pain, they probably had peripheral arthritis with the knee pain, they had heel enthesitis, and they had elevated CRP and the itchy scalp. So they, by definition, would also fulfill the criteria. That said, our patient was kept on books, referred for physiotherapy, and seen again in clinic, still had ongoing symptoms. That's just the background. Updated blood showed ongoing inflammatory response. Repeat MRI 9 months later showed this. Totally different MRI. Bone marrow edema was seen in this particular patient. Diagnosis, non-radiographic axial SPA. And again, very high disease burden. This is just to remind you all that what we're actually looking for in an MRI, so these are your stir sequences. This is the key thing, looking for bone marrow edema. These aren't diagnostic, but we also look for things like capsulitis, enthesitis, synovitis. And then your T1, you're looking for. Why is there a delay in diagnosis? And I think there's going to be a talk at this conference about a delay, the reasons for a delay in diagnosis. What you're really seeing is this poor healthcare professional awareness. That's a key problem. Patients are seen by general practitioners who aren't aware, physiotherapists who aren't aware, osteopaths who just are not aware of inflammatory back pain. Their teaching in rheumatology is limited. It's mainly focused on orthopedic teaching. Common myths. AS is thought as a male disease. How many of you think that this is only seen in men? And what you're looking at here is, even in looking in our cohort of patients, I've got about 700-800 patients with axial SPA. You actually see that 50% of patients are female and 50% are male. But if you break them down to non-radiographic and radiographic, you find more women will have non-radiographic than in men, and vice versa with radiographic. The problem with this is the average diagnostic delay as a result of this is greater in women. They have higher disease activity, greater functional limitation, and worse mental health. There's clearly a lack of diagnostic criteria. Imaging issues as well. You'll find that a lot of patients will have, they'll go with back pain, they'll have an MRI, and the MRI will be only of the lumbosacral spine, and they'll say they've had multiple MRIs, they're normal, so therefore they have no problem. They do the wrong MRIs. This whole concept that you can't have inflammatory pain because your CRP is normal. 60% of patients with axial SPA have normal CRPs. You can't have axial SPA if your HLA-B27 is negative, is incorrect. So be cautious when we're looking at these biomarkers. It's also a common presentation. Remember, back pain. Majority of people with back pain will actually have mechanical back pain, and that's our focus, or our colleagues' focus is this is just a mechanical problem. The problem with not identifying patients with axial SPA is this occurs in the formative phases of their lives. So these symptoms would interfere with their education, professional development, and social relationships. Much of the morbidity of axial SPA is established in the early years of disease, and we also know that response to pharmacotherapy is greater in patients with shorter disease duration. And lack of treatment in the early years of AS results in a lost window of opportunity for effective treatment. So what do we do with our patient? High risk assessment. We felt that this patient was high risk. Why did I say that? If you look at our patient, cigarette smoker, young age, and had active inflammation. So what I would do in these patients is not just sit with physiotherapy and anti-inflammatories, is get them onto biologics early. Which biologics? So this lady is planning for pregnancy. So this was a time pre the updated guidelines. We were mostly using sertolizumab in patients who were planning pregnancy. But these are the latest guidelines. So these are the Biologic Society of Rheumatology guidelines in 2022. And if you go through this, you will actually see that, yes, we're still using sertolizumab, it's all throughout, but now we can comfortably use anti-TNFs throughout pregnancy. And if you have low disease activity, the recommendation would be probably to stop the anti-TNFs around about the 3rd trimester if you have inactive or low disease activity. The rationale for that is then that would allow you don't have to then delay vaccination for your child by about 6 months. But the important updates are the IL-17s. Ideally stop it at conception, but only in very active disease, it's reasonable to continue with treatment. However, delay vaccinations in the baby for at least 6 months. But at present, with the JAK inhibitors, they aren't recommended in pregnancy. And this is very similar to the EULAR guidelines as well. So, early biological therapy rationale. Reduce structural damage and disability, greater efficacy when initiated early. HLA-B27 positivity predicts aggressive disease, so get on treatment very early. And high CRP also indicates active disease. This is also just showing, looking at non-radiographic and axial SPA, left and right. And the earlier you start treatment, the better your outcomes are as well. Smoking cessation, really important, not just in axial SPA, throughout all our autoimmune rheumatic disorders. And what we're seeing in our axial SPA patients, if you look at the DAM-BIO registry data, we're looking at the treatment adherence, if you look at the graph on the right. According to smoking status, if you are a current smoker, your treatment adherence is less favorable than if you are a never smoker. And if you look at the responses of BASDI, 50% on the graph on the bottom right, again, if you were a never smoker, you are more likely to respond or get a BASDI 50% improvement than if you were a smoker or an ex-smoker. The significance of smoking cessation is it improves biological therapy response rates, it reduces radiographic advancement. Importantly also, it lowers comorbid cardiovascular disease risk, and it mitigates the risks in those HLA-B27 positive patients of radiographic advancement. Obesity. In the last few talks, people have talked about obesity, and this is really important if you're looking at outcomes in patients who are overweight and on TNF inhibitors and axial SPA. It's interesting that when we talk about obese patients, we're talking about patients with BMIs over 30, but look at those who are overweight, which is a BMI of 25 to 30, which some of us, or a significant proportion of us in our patients have that sort of group. And we don't look at them as a problem, but they are a problem patient, because if you look at the data in just the middle group, which is the overweight, we all know about obese patients who have BMIs over 30, but even in the overweight group, which is probably majority of our patients, outcomes in those patients are less favorable than those who have a BMI of less than 25. So, pregnancy was successful in this patient, but a few months later, the patient started to develop psoriasis. And just to recall, a BSA of 3%, look at the palm of a hand of the patient, that's 1%, and the number of palms of hands would equate to the number of percentage of their body surface area of psoriasis. And I believe this lady had a BSA of about 6%, so quite significant psoriasis following her pregnancy. So treatment needed to be reassessed, and the disease had progressed from just being simple spinal SPA to psoriasis with axial involvement. So, on the basis of that despite being on biologics, they developed psoriasis and they had axial disease, we had ended up switching this patient to an IL-17. And the IL-17 of choice at that time was Cosentyx. It was the only one that was available easily for us. We started on IL-17, but unfortunately, soon after, the patient developed inflammatory bowel symptoms. Within about 4 to 5 months of initiating treatment, they presented with abdominal pain, diarrhea, and rectal bleeding. They had a workup, fecal calprotectin levels were elevated, and a colonoscopy confirmed inflammatory changes. The suggestion was that this was possibly exacerbated by IL-17 inhibition, and we know that IL-17 plays a protective role in intestinal homeostasis, and its blockade can disrupt the gut barrier function and trigger inflammatory processes in susceptible individuals. The treatment implications of this was that we stopped the secukinumab, obviously engaged with our gastroenterologist, and we had to think of something else. So what did we think of? We considered a JAK inhibitor, because that's the next line of treatment that's available to us, and the JAK inhibitor of choice was upadacitinib, which was available. Patient went on upadacitinib, but still had pains. If you looked at the disease burden, they had BASDI when you did the scoring of 6, they had spinal VAS of 6, so they continued to complain of spinal pain. They had tiredness. They felt unrefreshed when they were waking up in the morning. They developed poor concentration, brain fog, headaches. So not an unusual constellation of symptoms we're seeing in our patients with other autoimmune rheumatic diseases. And this becomes therefore a diagnostic challenge. Has this patient developed fibromyalgia? I've taken a little from the notes of our patient, where has particular pains were. So most of you know this is the WPI sheet, and the patient had pains everywhere, and look at the symptom severity. So the patient was potentially developing fibromyalgia. So this becomes challenging. Patients complain of spinal pain. So what you need to understand, what we're trying to work out is what is the mechanism of that spinal pain? Is it due to active inflammation, or is it due to a chronic widespread pain syndrome? What I ended up doing was doing a repeat MRI in this individual, and if you remember the first MRI, and this is the repeat MRI, we found that there was no evidence of bone marrow edema in this individual. This prompted us to suggest that the ongoing symptoms, despite being on a JAK inhibitor, was unlikely to be related to active inflammation and more likely to be due to a chronic widespread pain syndrome such as fibromyalgia. So there's no evidence of objective inflammation on either bloods at this stage, which I didn't mention, and the imaging was actually normal. So in our fibromyalgia patients, I'm sure we'll have talks on fibromyalgia. It's a multimodal, multidisciplinary approach with physiotherapy focusing on a supervised exercise program, clinical psychologists to consider therapies such as cognitive behavioral therapy, possibly cognitive functional therapy, mindfulness, to help with both pain and sleep management, also signposting our patients to sleep hygiene, and medications such as amitriptyline, duloxetine, and potentially pregabalin as well is the line that we're taking, and continuing with JAK inhibitors as well. This graph is just basically showing you that those patients with fibromyalgia tend to have a worse response from a BASDI perspective. And this is also showing, the graph on the right basically shows that those patients with fibromyalgia tend to have higher disease activity or composite scores, and even though they do improve, at the end of 12 months they still have ongoing quite high disease activity scores. So it's important to address fibromyalgia and consider fibromyalgia, and the most important point here is that if you do suspect, you try to suspect, in patients who aren't responding, do consider fibromyalgia, because the treatment is not to change a biologic, but to treat the underlying fibromyalgia itself. So, in summary, we've got our patient who had pre-radiographic axial SPA with high-risk features. We started treatment with sertolizumab. I gave reasons for that. Unfortunately, after their pregnancy, they developed psoriasis, so they developed this new skin manifestations. They were then switched to an IL-17 inhibitor. This unfortunately resulted in them developing an inflammatory bowel pathology, and therefore they were switched to upadacitinib. And whilst on upadacitinib, despite having good disease control, they had ongoing symptoms of pain. These same pain symptoms were non-inflammatory, which required additional management. So the final slide, the key learning and clinical implications here are, number one, gender considerations. Female patients with axial SPA experience longer diagnostic delays and often present with different symptom patterns compared to males. Sometimes we'll call them fibromyalgia. They may well have fibromyalgia, but make sure you don't miss the autoimmune inflammatory disorder as well in those individuals. Family planning. Treatment selection must consider pregnancy planning, especially in our Axial SPA, who are a young cohort of patients. Sertolizumab remains the preferred biologic during conception and pregnancy due to minimal placental transfer, but I mentioned the new guidelines, which says you can try other anti-TNFs, but consider changing them at the 3rd trimester if they've got low disease, or stopping them if they've got low disease activity. Axial SPA patients require ongoing vigilance for emerging comorbidities like psoriasis in our patient, IBD, and more importantly, fibromyalgia. Treatment selection should anticipate and address these associated conditions proactively. And finally, the evolving treatment paradigm requires tailored therapy based on genetic markers, comorbidities, lifestyle factors, and patient preferences. There is no single treatment pathway that fits all patients. Thank you.
Thank you, Professor Hasan Tahir, for such a comprehensive presentation. Our next speaker is Dr. Anila Nisar, Assistant Professor and Consultant Rheumatologist at KRL General Hospital, Islamabad, Pakistan. Dr. Nisar is a dedicated clinician and academic, contributing actively to the growth of rheumatology practice and medical education in Pakistan. Her talk, Rheumatoid Arthritis, Treat to Target, JAK inhibitor updates and safety data, centers on one of the most important aspects of modern rheumatology. Please join me in welcoming Dr. Anila Nisar to the stage.
The title of my talk is Rheumatoid Arthritis, Treat to Target, JAK inhibitor updates, efficacy and safety data. First of all, there are no disclosures for me, and my study involves my talk is basically divided into 2 parts. First part is about rheumatoid arthritis with treat to target strategy, and second part is about the safety and efficacy of JAK inhibitors, which is one of the very hot topics in these days. So rheumatoid arthritis is a chronic systemic inflammatory disease characterized by joint pain, swelling and progressive damage. And without treatment, it can cause to significant joint deformities and deterioration in the quality of life. But if we treat adequately with the treat to target strategies, we can prevent the joint deformities and a better quality of life. The worldwide prevalence is about 0.21% according to latest 2021 Global Burden of Disease study, and it affects females twice as commonly as males. And the risk of developing rheumatoid arthritis is 3.6% in females and 1.7% in males. This high figure implies that there must be some strategy either to prevent this disease or to treat this disease at an earlier stage. So first look at the stages of development of rheumatoid arthritis. In healthy individual, when there are certain risk factors, there is a preclinical stage of rheumatoid arthritis. Then there is a subclinical stage of rheumatoid arthritis, which later on becomes early rheumatoid arthritis, and if not treated earlier, it can develop into chronic rheumatoid arthritis, fulfilling the diagnostic criteria. So we must focus on these 2 points. First point is to prevent the development of rheumatoid arthritis, and second is to treat it at an earlier stage to prevent chronicity. So these are certain important studies that were done to prevent the development of rheumatoid arthritis from 2019 onwards. First study was Prairie, in which rituximab was studied, then Strepra, then Treat earlier, Apipra and ARIA trials, and the latest trial was done by using hydroxychloroquine. But no medicine prevented the development of rheumatoid arthritis. However, abatacept has some significant role in delaying the onset of rheumatoid arthritis by about 18 months. So second is to treat the disease. We cannot prevent the development of disease, we can a bit delay the disease, but we can prevent the disease by early diagnosis, setting the target as low DAS or remission. For this, we have to assess the disease activity every 1 to 3 months by using various tools, and then we modify the treatment according to the status of the patient and comorbidities. These are various tools to measure the disease activity. Commonly used are DAS28, Simplified Disease Activity Index, and Clinical Disease Activity Index. So to achieve the target of remission or low disease activity, we monitor the patient every 1 to 3 months and adapt our therapy according to the status of the patient, disease activity, and comorbidities. A big study involving 22 studies, this was a meta-analysis, it was published in 2021, treat to target strategies in rheumatoid arthritis. So all the studies done on early rheumatoid arthritis cases as well as established rheumatoid arthritis cases, they clearly showed that those who were treated via using intensive regime, they achieved remission in a much big percentage of the cases in both the patients, early as well as established rheumatoid arthritis. And the results showed that this treatment was cost effective as well as there was no added side effect. So initially we had the treatment including conventional synthetic DMARDs like methotrexate or leflunomide, and if there was no response after 3 to 6 months, the option was biological DMARDs, and if there was no treatment, option was again biological DMARDs. But the problem was that all the biologics were injectables, they needed infusion facilities, there was some needle phobia of the patients, risk of infusion reactions, and most importantly, high cost. So there was a need for some therapy that was equally efficacious to biological DMARDs, but with oral route and lesser cost and lesser risk of side effects. So the new development was JAK inhibitors, which are oral treatment options and equally effective as shown in EULAR 2022 guidelines, that after the failure of methotrexate, if a patient has poor prognostic factors, we can add either a biological DMARD or a JAK inhibitor. Then in 2025 guidelines, even the presence of poor prognostic markers was eliminated. We can straight away switch to biologics or targeted synthetic DMARDs after methotrexate failure. So this signifies the importance of JAK inhibitors. JAK inhibitors or JAKinibs, what are these? These are oral, very targeted therapies for various immune-mediated inflammatory diseases, and our focus today is on rheumatoid arthritis. These are protein tyrosine kinases that bind to type 1 and type 2 cytokine receptors and mediate the JAK-STAT signaling pathway. And JAK inhibitors are the drugs that inhibit the activity of one or more of these enzymes, that is JAK1, JAK2, JAK3, and tyrosine kinase 2. So this is a beautiful diagram of JAK inhibitors, JAK-STAT pathway. These are type 1 cytokine receptors, type 2 cytokine receptors. This is the extracellular part, this is intracytoplasmic part. JAK enzymes, 2 to 3 JAK enzymes are attached to intracytoplasmic part of these cytokine receptors, which in turn mediate the JAK-STAT pathway. So for junior colleagues, only briefly I will tell the mechanism of action of JAK-STAT pathway. Whenever a cytokine ligand binds to the receptor, there is autophosphorylation of JAK enzymes, which in turn leads to phosphorylation of the receptor, which recruits the STATs and creates a docking site for the STATs. STATs are phosphorylated. Phosphorylated STATs then detach and dimerize and move to nucleus, where they are involved in gene transcription. So JAK inhibitors act at this level and they prevent the phosphorylation of receptor. So these are 5 approved JAKs for rheumatoid arthritis: tofacitinib, baricitinib, upadacitinib, filgotinib, and paficitinib, and first 4 are available in Pakistan as well. As these JAK inhibitors act as a very molecular level, they are very targeted, these are oral therapies, and this is evident from this diagram as well, that JAK inhibitors are efficacious in almost all immune-mediated inflammatory diseases, that is rheumatoid arthritis, psoriatic arthritis, psoriasis, ankylosing spondylitis, inflammatory bowel disease, and JIA. Green color shows efficacy, and red color shows no efficacy, and yellow is the intermediate. So JAKinibs are efficacious in wide variety of immune-mediated diseases. So first JAK inhibitor was tofacitinib, that was approved in 2012. Then in 2018, baricitinib was approved by FDA, and then 2019, upadacitinib. Filgotinib was approved only by European Medical Agency. So a few slides about the role of JAK inhibitors. First of all, tofacitinib. The landmark trial for tofacitinib was oral solo trial. in which it was compared with placebo, and the results were significant at 3 months. ACR 20, ACR 50, and ACR 70 were much superior than placebo. Then oral standard trial, which compared tofacitinib with adalimumab, and again the results were comparable. Then oral START trial, in which tofacitinib was compared with methotrexate as a single agent. Again, tofacitinib, both the doses were much superior to methotrexate alone. Then oral strategy trial, in which methotrexate plus tofacitinib was compared with methotrexate plus adalimumab. So comparison was with adalimumab, and the results showed that tofacitinib and methotrexate versus adalimumab and methotrexate both were equally effective. Tofacitinib was non-inferior to adalimumab, which is a TNF inhibitor. So this was a big trial published in 2019, which compared the safety and efficacy of tofacitinib for up to 9.5 years. Oral sequel, which is a long-term extension study of previously done studies on tofacitinib. So safety data and efficacy data for up to 9.5 years showed that tofacitinib has sustained efficacy. Sustained efficacy from 3 to 4 months till 5 years. Then baricitinib. It is JAK1 and 2 inhibitors. Similar studies were done with baricitinib as well. First of all, RA build study, in which it was compared with placebo, and the result was superior to placebo, as well as joint erosion score and joint space narrowing was much reduced. Then second was RA begin trial, in which it was compared with methotrexate and found to be more effective than methotrexate. Then RA beam trial, in which it was compared to adalimumab, and baricitinib was found to be more efficacious than adalimumab, but some risk factors, some adverse effects were more with baricitinib. Then RA Beyond study was published in 2021, which compared the patients taken from both the trials, that is RA Begin and RA Beam trials. The result was that at week 148, simplified disease activity score, low disease activity was achieved in up to 61% of DMARD naive patients and 58% of methotrexate resistant patients with the use of baricitinib, which was a very good result. And then it was studied up to 6.5 years, and treatment up to 6.5 years showed sustained efficacy. Then another trial in which the reduction of baricitinib dose was studied, but the results showed that baricitinib 4 mg was better than baricitinib 2 mg. Then upadacitinib. Similar studies with upadacitinib, select compare study by comparing upadacitinib with adalimumab. Results were superior for upadacitinib in all these domains. Green color is showing, upadacitinib, and purple color is for adalimumab. So upadacitinib was superior. Then select beyond study, which was done in difficult to treat RA cases that were resistant to biologics. Again, the result was superior for upadacitinib, and this result was up to 260 weeks, that is 5 years. Then select choice trial, in which it was compared with abatacept. Results, efficacy was superior to abatacept, but again certain side effects were observed. Then select early trial, which gave us the results for up to 5 years, and these 5 years results were much superior than methotrexate. Similar studies done with filgotinib, done in methotrexate resistant patients, done in difficult to treat RA cases, and done in treatment naive cases, all the showed comparable efficacy with similar risks of side effects. And again, the study was done up to 5 years, and the results were sustained. Sustained results up to 5 years. So all was good till now, but then there was a safety concern. In 2021, FDA issued a black box warning regarding the JAK inhibitors. There were some consideration about increased risk of cardiovascular side effects as well as malignancies and thrombotic events. So a big landmark trial was published in 2022 in NEJM, that is cardiovascular and cancer risks with tofacitinib in patients with rheumatoid arthritis, that is oral surveillance trial. It was an open label non-inferiority trial comparing tofacitinib, both the doses with TNF inhibitors, and the endpoint was non-inferiority of MACE and malignancies for tofa versus TNF inhibitors. So it was basically a non-inferiority trial. But this point was not met. Tofacitinib has increased risk of cardiovascular events and malignancies, excluding non-melanoma skin cancer compared with TNF inhibitors. Secondary endpoint, that is efficacy, was similar to TNF inhibitors. So increased risk of MACE as compared to TNF inhibitors, increased risk of cancers as compared to TNF inhibitors with both the doses of tofacitinib, increased risk of opportunistic infections, but more with tofacitinib 10 mg dose, increased risk of pulmonary embolism, but more with 10 mg BD dose, increased risk of DVT and thrombotic events. These two were more with tofacitinib 10 mg twice a day dose. Although tofacitinib 10 mg twice a day is not being used these days in rheumatoid arthritis. So this study had several important questions. Do JAK inhibitors increase the risk of MACE above placebo? Is the risk of MACE more with JAK as compared to placebo? Or the risk of MACE is more with placebo as compared to JAK inhibitors? So for this, a further sub-analysis of oral surveillance trial was done and two subpopulations of tofacitinib users were identified. This study was published in 2023. It identified two groups of patients. One was a high-risk group and second was a lesser risk group. High-risk group included patients more than 65 years who ever smoked, means current smokers or past smokers. These were big risk factors. And the other group was age less than 65 who never smoked. So the results were, red color graph is for TNF inhibitors and black is for tofacitinib. So overall population, the risk of all the adverse effects was more with tofacitinib. But when we compared high risk group versus low risk group, it showed that the risk is more in high risk group, but for low risk is comparable in both the groups. All the side effects are equal with tofacitinib as well as TNF inhibitors. This study was done only on tofacitinib. Again, a similar study, STAR-RA, published in 2021 or 22. This has similar results. It also compared tofacitinib versus TNF inhibitors and similar risk of composite outcome of hospitalization for MI, cardiovascular events, CVAs, as well as malignancies in both the groups. Then another important side effect that was being considered for filgotinib, it is currently available in Pakistan, but the major concern for which it is not FDA approved is infertility in males. It has certain adverse effects on semen and sex hormones in male. For this, a big study was done by the name of MANTA and MANTA-RAY in patients with rheumatoid arthritis and inflammatory bowel disease who were taking filgotinib. Conclusion was that once daily filgotinib 200 mg for 13 weeks has no measurable impact on semen parameters or sex hormones in men with active IBD or inflammatory rheumatic diseases. The primary outcome in this study was a decline in semen or sperm count to less than 50% at 13 weeks, as the life cycle of sperms is up to 13 weeks. So this was the primary endpoint, and it was similar in filgotinib as compared to placebo. So other side effects which are considered in or which are more with TNF inhibitors are weight gain with filgotinib, herpes zoster, especially serious herpes zoster, increased risk of opportunistic infections and tuberculosis, increased risk of GI perforations, but these are minor side effects, mild rise in CPK elevation and mild disturbance in LFTs, as well as certain hematological abnormalities. So most recently, a big meta-analysis has been published regarding safety of JAK inhibitors in immune-mediated inflammatory diseases, a systematic literature review informing 2024 update. And the conclusion of this meta-analysis was, risk of adverse events is generally more in patients with immune-mediated inflammatory diseases due to high burden of inflammation in these diseases. So number one, inflammation. Number two, more presence of comorbidities. Number three, background use of methotrexate and glucocorticoids. All of these are risk factors for cardiovascular events as well as malignancies. So the main thing is to control the active inflammation to prevent these side effects. JAK inhibitors are highly effective in immune-mediated inflammatory diseases, but they should be optimal use by considering the ratio between benefit versus risk in every individual patient. So based on these studies, certain risk factors were considered for the use of JAK inhibitors. Age more than 65 is a risk factor, history of current or past smoking, diabetes, obesity, hypertension, other risk factors for malignancy like history of malignancy, history of MI, heart failure, or inherited blood clotting disorders, or patients taking combined oral contraceptive pills or hormone replacement therapy. On the basis of these risk factors, a very important tool is designed for approximate risk stratification while we prescribe JAK inhibitors. So we should consider this tool in which non-modifiable risk factors are plotted on y-axis and modifiable risk factors are plotted on x-axis. Score is calculated and then plotted. If the patient falls in green zone, it means JAK inhibitors can safely be given. If patient falls in yellow zone, it means we can consider JAK inhibitors on individual basis, and red zone means totally contraindicated. So take-home messages include early diagnosis of rheumatoid arthritis to prevent joint deformities. Aim for target should be remission, and if not, low disease activity. Treat to target strategy by using composite disease activity measures every 1 to 3 months and to adapt therapy accordingly. And second part, judicious use of JAK inhibitors by considering risk factors and weighing risk versus benefit in individual patients. And lastly, only for juniors more than equal to 65 years old age with active or ex-smoking status, history of MACE, is totally not a candidate for JAK inhibitors. Thank you very much.
Hello. Thank you very much, all the speakers. Very insightful and very knowledgeable talks. Thank you very much. We have few questions, and I'm going to start with the first question is from Dr. Saira. And the question is that it is from Dr. Haroon. Okay. The question is that if the patient has axial psoriatic arthritis along with peripheral arthritis, so we know that methotrexate does not work in axial disease. So we see patients coming with both the symptoms, axial and peripheral. So what would be your starting choice of treatment in such patients? Would you go for methotrexate, or would you directly go for JAK or biologics?
I think that's an easy one. So I think definitely in my practice here in Pakistan, purely talking about the affordability point of view, JAK inhibitors. Can you hear me? So JAK inhibitors, definitely I start off with the JAK inhibitors plus methotrexate. I start both at the same time from the very day one, of course, after making sure the usual blood tests and all those. So usually my first, of course, port of call is to start with the JAK inhibitors plus methotrexate. In those patients who I'm sure that I'm going to keep on JAK inhibitors for long term, or the biologics on the long term, on those patients, of course, methotrexate will not be escalated to 25 milligrams. That's what I usually aim for, but only if there is no concomitant targeted synthetic DMARDs or the biologics.
Okay. I think we have one more question from Dr. Haroon.
Yes. There is one study going on at our center through APLAR grant. Is a double-blind randomized controlled trial on combination of methotrexate with tofacitinib versus methotrexate with leflunomide. So which is on the way, and hopefully by mid of next year we would be analyzing the data. It's like 6 months and 1 year outcome of patients with psoriatic arthritis, tofacitinib, methotrexate versus leflunomide versus methotrexate.
Good to see.
Yes. a question by Dr. Kinzavati. What percentage of patients with skin psoriasis develop arthritis, and within how many years? This is the first part. The second part is, how do you weigh JAK inhibitors against anti-TNF and interleukin-17A inhibitors in terms of skin and joints domain?
So the first thing is about the prevalence. So we know about 30 to 40%, and most of the studies have shown the patient with the skin psoriasis would develop psoriatic arthritis. Regarding how long will it take to develop psoriatic arthritis, so the average is around 10 years, but that again depends on the genetic subset the patient belongs to. So if the patient belongs to HLA-C 0608, for example, so usually those are the patients who would take at least 9-10 years. And these are the patients who would have a severe skin psoriasis. But the patient who belong to HLA-B27 subset, for example, those patients would develop concomitant, mostly, psoriasis and psoriatic arthritis, usually within a year or thereabouts. So the development of psoriatic arthritis depends, as I said, on the genetic, the class they belong to. But usually, mostly, it's around 9 to 10 years if you talk about. Regarding the therapies, whether you're talking about the targeted synthetic DMARDs, TNF inhibitors, IL-17 inhibitors, they all work extremely, extremely well. We all know. Hardly I remember there are any head-to-head trials. But again, if you look at the data, for example, it's very compelling. For JAK inhibitors, for example, if you talk about especially upadacitinib, for biologic failures, for example, there's a very, very good response for those patients. In Pakistani population, naturally, the pocket comes first. And here, the JAK inhibitors are extremely cheap compared to those biologics. For example, the anti-TNF, if you talk about the recurrence of the TB and all this you talk about, of course, there's a risky business in that. And if we have the option of choosing a milder version of that drug as got the pocket-wise, and of course, definitely lesser reactivation of TB, if you talk about, with the JAK inhibitors compared to anti-TNF monoclonal, definitely my choice comes the JAK inhibitors first in those patients. IL-17 definitely is a very good option as regards the infection and all this. But again, as I said, that depends on the pocket of the patient. If somebody can afford, definitely IL-17 is a very good choice for skin disease, definitely superior compared to the JAK inhibitors in my eyes. But arthritis-wise, both works the same. The spinal data, axial data, if you can look at, whether you look at the enthesial data or the peripheral joints, they do work as regards, whether you look at the IL-17 or the JAK inhibitors. They're all preferably more or less the same.
Thank you, Dr. Haroon. There's one question from Dr. Hasan. Dr. Hasan, that how do you interpret fat metaplasia on an MRI? Because sometimes the history is not very typical and you go for an MRI of the sacroiliac joint and you find only fat metaplasia without any edema. And there's a little part of it. It's how do you interpret as what things go in favor of that this is chronic sacroiliitis or this is a physiological fat metaplasia?
I think the key thing here is you don't look at an MRI independently. You know, you have to put it into clinical context. And remember, it's all about judgment. So you have to take a story first for what the history actually presents. Then you look at, you know, all the other markers as well, and then look at the imaging as well. Where is the fat metaplasia? Is it just in the SIJ? Is it in the spine as well? So it's not just in isolation. So a lot of we have this conversation all the time, and we have weekly MDT for our AS patients, and it's a question that's always brought up. So radiologists will report it, and then as soon as you have a clinical input into it, it's very helpful. So the point is, don't just use an MR independently, put it into context.
Thank you very much. This is the last question from Dr. Anila.
There's a question for Dr. Anila from Saira Pauli Foundation Hospital. She's asking about the practical experience of filgotinibs in elderly population so far. You know about it. Any complications, side effects?
So is it for me?
Assalamu alaikum. As I have showed a tool for measuring the risk versus benefit in patients with rheumatoid arthritis, age more than 65 has a score risk of 1 And if only patient is aged more than 65 but no other risk factors like no current or past history of smoking, patient is not a diabetic or hypertensive, or if he has diabetes or hypertension that is very well controlled, then we can use JAK inhibitors safely in this population as well. But ideally, if we have some other options like TNF inhibitors or interleukin 6 inhibitors, mostly we prefer these two agents more as compared to JAK inhibitors in elderly population. But JAK inhibitors are not totally contraindicated only on the basis of age.
Thank you very much.
Thank you to our speakers and chairs for a thoughtful exchange. I would now request the worthy chairs, Professor Babar Salim and Dr. Alam Zeib, and co-chair Dr. Syed Ali Rukh, to present a token of appreciation to our speakers. Our first speaker of this session, Professor Muhammad Haroon. Our next speaker, Dr. Hasan Tahir. And finally, Dr. Anila Nisar. Now we would like to request Professor Ahmed Said and Dr. Rafaqat Hamid to present a token of appreciation to the chairs of the session. Professor Babar Salim, Dr. Alam Zeib, and lastly, Dr. Syed Ali Rukh.